Good afternoon, ladies and gentlemen. Our webinar is beginning. My name is Steve Love, President and CEO of the Dallas-Fort Worth Hospital Council, and we certainly appreciate you being here today for this educational webinar. It's hosted in coordination with Snowflake, an associate member here at the Hospital Council. Snowflake operates a platform that provides data storage via cloud computing and allows for data analysis and simultaneous access to data sets with minimal latency. Today's topic, accelerating clinical research, harnessing multimodal data, AI in a secure collaboration. Great topic. We look forward to hearing two national experts. In healthcare, the convergence of data, AI, and collaborative efforts is reshaping the way we approach medical research, especially in an academic environment. And this discussion is going to help us learn about creating opportunities to improve patient outcomes and challenges for research infrastructure. We have two excellent speakers today. Murali Gandhirajan is a global healthcare CTO at Snowflake, and Joe Warbington, an industry principal in the healthcare at Snowflake. Murali has had more than 2 decades of experience as a trusted advisor to many leaders in healthcare and life science organizations. Joe has worked with health technologies and data for over 15 years, and a real emphasis related to population health and how we reduce clinical burnout. We've got a great turnout today. We're looking to a great presentation. Before we begin, one administrative item. If you have questions, you can either put them in the question box or the chat box, and we'll try to answer them at the end of the webinar. And so with that, ladies and gentlemen, I'm going to turn it over to Joe. Thanks, Joe.
Thank you, Steve, and thank you, everybody. I see Murali's hopped on too, so Chris, if you're back there, you might want to spotlight him as well. But really happy to be here. It's been a few years since I've worked with the DFW Hospital Council. I might be a familiar face from a couple of years there, working at Epic and then also at Click. So there's some familiar faces in the audience there. As Steve had mentioned and opened up, we have a lot to cover today around clinical research, multimodal AI, and secured collaboration. So you have some familiar faces. Everybody will get our contact information, LinkedIn, be more than happy to connect and share what we see in research and beyond, just with healthcare providers, payers, life science companies around the nation, but in the DFW area especially. So, if anything out there jumps out, just let us know. We'll be monitoring the chat as well. You can throw questions in, we can answer them during the fly, and we'll have some time at the end as well. Murali, you want to say hi?
Hi, everyone. Nice to be here and looking forward to this webinar. I'm Murali Gandhirajan, Global Healthcare CTO at Snowflake. Over to you, Joe.
Perfect. Okay, we're gonna jump in. Got to always have the legalese up front. Some of the things we show might change names, that type of thing. Please don't make decisions based on exactly what you hear from us, but we're going to get into the weeds a little bit on research. So today, what we prepared for you has really been the culmination of a lot of many months of travel, meeting our customers and working with organizations, much like yourselves on the line, covering these key elements of where the technology can really help them accelerate medical research. So Murali and I have, we've been traveling around. We were just together in Miami just the other day, and I'm based in Tampa Bay. Murali's up in Connecticut, and so we're constantly flying around. We'll meet you where you're at. But today we're going to cover a couple of these key things. We'll spend most of the time in the middle of the key elements, and then hopefully we get a chance to meet up too. I'll share a local Dallas event that's just around the corner. So first up, just kind of take folks through what we hear, what we see, and what many of you have probably experienced for many years is that academic medical centers in particular have a lot of business imperatives that, research is a huge component of what they do. And we're going to talk through each of these key areas, pillars, the challenges. And so note that, research happens at a variety of levels. There's a lot of data. It's the volume, but it's also many different silos. That's internal to your organization and external. So we're definitely going to touch on elements of that. And that really factors into the second one. Clinical research isn't done at just one institution. It's usually a combination of many different parties. That's going to help you get the diversity of the candidates, the members of the studies, for instance, and reducing bias in academic research. So we're going to talk about how that can happen and why a lot of organizations that, for many years and still today have a lot of on-premise data, where the cloud can fit in there. Also, it's really important that when you do work with external organizations, that the data is secure and it's easily accessible. That it hasn't been the case for a long time, but one of the reasons I joined Snowflake was particularly in this area. So we're gonna showcase a little bit of that and talk through how organizations are doing it, and of course preserving the privacy. As a patient, like many of us, your data is very sensitive and secure. You don't want it in the hands of the wrong folks, and you don't want to see HIPAA violations happen. So we have to protect, secure, mask the data, and often this comes down to technologies that do tokenization, which we'll also touch on. As you might imagine, and why we're here and why we work with a lot of organizations, is that there's a significant data challenge that's part of this. So we're going to talk about the high volume and just the vast scale of data, but also the multimodal side of things, and that is the different variety of data that we'll talk through, whether they exist internal or external. Oftentimes, when you're doing these collaborations with parties, you're copying and sending the data to them. And now, if you think about it, there's 2 copies of PHI out there. And all these things are stitched together. So every time you send it, somebody's got a copy. You might have to send changes back and forth. That takes time, it takes money, and often there's another element of security that's related. Did we secure it before we sent it out? Ooh, we forgot to mask a field. Now we have to send a correction, ask them to destroy data. And you can imagine how doing this with multiple institutions really results in really lengthy processes. There's a lot of hesitation in doing some of these things, and it takes a lot of resources to do that. We ultimately want to help organizations cut that down and work on smaller, not smaller, but fewer copies of the data. And so what Snowflake brings, just as a quick high level, and we're not going to talk a lot about just what our technology does. We want to talk about what institutions are doing with it. But if you're new to it, Snowflake is a platform with data at the core, of course. We interoperate with all kinds of different systems. We work a lot with your EHRs, with claims data, and we allow you to use the power of the cloud to scale it and use it as effectively a utility so that nobody competes when you're doing resources or using resources. Your data science team can operate on the same data that your analyst team is using, that your researchers are using, and you're not waiting for these technologies to kind of compete. And AI is baked into the platform, and you'll see these things come to light. But really importantly is the content that comes along with the data cloud, and that's where we're going to talk through a couple technology partners. Some you may have already heard of or work with. A couple of our system integrators and consulting groups have built accelerators that you can stand up really quickly. And important to research and many other elements for healthcare is there's a lot of data that you'll never have on premise or in your own organization or captured in your EHR. And so we bring about data and applications that easily integrate with what you have. To talk just a little bit more about the platform, starting from the left-hand side, we see all kinds of different types of data coming into the Snowflake platform for our customers. And that's typically a huge volume, comes from the EHR, from the Epics, the Cerners of the world, but also claims data, which is a really important aspect of different projects, and real-world evidence data from might be pharma companies or fitness devices. You name it, if it's digital or we can digitize it, it can be used in the platform. And we're going to talk a little bit more about the unstructured or multimodal side, being images, DICOM, audio, video, text that your doctors and nurses are typing into the EHR is typically unstructured. Snowflake works with that as well. So we land it. You can use many different workloads, but everybody's really operating on a single piece of that information. And an important part is that along the bottom, we're built in the cloud, for the cloud, and on the cloud. And it doesn't matter if you have preference for AWS, Google, or Microsoft Azure. We work on all of the clouds at the same time. It's it's the same experience no matter which one you choose. And often we find institutions may have a preference for one, but you can't dictate what your trading partners use, what the pharma companies, the payers, the other institutions have for their cloud. So Snowflake interoperates across all three clouds. And ultimately, we want to get to the outcomes that your business teams, your researchers use. And I highlighted, research and discovery being one of the major, data products and areas that our customers work in. So long-winded way, and there's a lot more to Snowflake. Happy to help out and get folks more, information on that if needed. But we really want to focus today on these 4 key areas for accelerating and augmenting your clinical and healthcare research. Number 1 being accelerating, and where Gen AI and these things fit in. We're going to touch on a concept called the trusted research environment and the ability to do multimodal data. And then we'll get through a couple of these other ones throughout. Please ask questions. All these slides will be provided as well. And there's links that we put in the slides to jump you out to more details as needed. So first off, we're going to talk through accelerating academic research. Murali?
Thank you, Joe, and good afternoon, everyone. So if you take a look at what happened, when it comes to the world of computing, there is a significant advancements in terms of the advancements in CPUs, the advancements in the underlying hardware, in terms of that getting more and more powerful, the rise of GPUs. And the associated computing infrastructure, the rise of generative AI as a technology, and if you take a look at what that is actually opening up, is a great opportunity to leverage the power of the computing infrastructure and the technology to truly accelerate academic medical center and the associated research that happens within the academic medical centers. And why that is significantly important is because with the rise of such such technologies and the underlying computing infrastructure, we are now able to tap into multimodal health data, truly multimodal health data, and now we have ability to process them in a way that it is extremely fast and easy and quickly able to generate the insights that truly drives outcomes and values when it comes to the research, right? And if you take a look at healthcare, we deal with structured data, right? The data which is coming in the form of clinical encounters of the patients, patients' claim information, the diagnosis, the medications, and so on and so forth. And then we deal with semi-structured data, which is essentially, if you take a look at interoperability, healthcare interoperability data, the FHIR is a JSON format. HL7s are its own proprietary hierarchical format. And the patient-reported surveys are usually XML, which are, it's a format in its own. Having ability to process these semi-structured data then becomes super critical, right? To unlock the insights that are coming on with this type of data topics. And then there is huge unstructured data, right? About 80% of the healthcare data is unstructured in the form of medical imaging data, whether it's a DICOM or a pathology images. And then we are talking about data coming out of medical devices in the form of waveform data. We have data coming in the form of audio and video recordings. We have data coming in the form of discharge summaries and clinical notes or notes captured across patients' care continuum. And all of that data has goldmine of information that can truly drive value from an academic medical research standpoint. So in order to tap into this type of a advanced computing infrastructure and the ability to handle multimodal data, you are really looking at a platform that has all of these capabilities that are baked into it in a way that it is easy to use, in a way that it is scalable, in a way that it is highly performant, so you can focus on truly generating the research insights from the data that you have. Right now, with that, if you can go to the next slide, please, Joe. Snowflake has ability to handle structured, semi-structured, and unstructured data. When you talk about the semi-structured data, for example, fire data is coming in the form of JSONs, right? And JSON is a first-class object within Snowflake. And you can directly take the data, load it into Snowflake, and use a simple SQL dot notation to truly understand the individual data elements that are coming in a JSON format and stage the data in a way that it is conducive for analytics. With Snowflake's ability to support unstructured data, you can now tap into the unstructured medical images, for example, that are sitting in a storage bucket. And you can use something like DICOM parsers to extract the metadata information that is coming out of those medical images, load them into Snowflake. So you have a complete repository of all the metadata informations from that medical images, which you can then use it to slice and dice and get to the images of interest from a research perspective, right? And you can use the same method to read in a DICOM medical image and start building predictive models, right? It can be an image classification model. For example, you may want to read in a chest X-ray, and you want to detect the presence of pneumonia, for example, in that chest X-ray, right? And all of that is made possible, using Snowflake's ability to support, structured, semi-structured, and unstructured data, and all of these. Data processing can happen in parallel. What do I mean by that is, with Snowflake's ability to scale in, meaning scale up, scale down, and scale out, you can really throw a higher computing infrastructure for very complex workloads. For example, if you are really trying to generate, or you are trying to train a classification model for the pneumonia detection, right? For example, you have ability to choose a higher computing infrastructure. You can scale it up, and then once you are done and the model is trained, you are deploying it for inference purposes. You can really scale down and deploy it on a lower computing infrastructure, and you can only pay for what you use, right? From a capacity perspective.
That's a big thing that I wanted to note that real quick, because lots of institutions think and often go out and buy a high computing platform, a high-end computing platform, have to buy a huge box, have a data center for it, whether it's an Netezza, HANA, Watson, the things I've seen across Texas. And this truly is, you can start small and scale up as needed. And I think that's a huge thing that we're finding allows even smaller institutions to have the power of, you name the institution that's the leader in it, they're going to have that same amount of power available, but not have to pay for it all up front. And I think it's a leveling factor for research that we see.
Yeah, certainly, Joe. It's a great add-on. If you can go to the next slide, please.
Yes.
I mean, we can really talk about all of those data, multimodal health data topics, and talk about how it can be handled within Snowflake. But I truly wanted to pick a three and give you a sample of how that can be done on Snowflake, right? So talked about fire data. The fire data comes in the form of JSON. JSON is a first-class object. What you can do is you can take that entire JSON, the fire resource, which is essentially coming in the form of a JSON format, throw it into a variant column within Snowflake, and use a SQL dot notation to kind of unpack the underlying attributes or elements within that JSON, and essentially spin up a target table that represents each of the fire resources, whether you are talking about patient demographics or immunization or medications or so on and so forth, right? All of those are fire resources, and boom, you have a entire data translated, from the fire format into a structured data model, which essentially is a fire data model, right? And you can layer in all sorts of analytical, capabilities on top of that data to truly generate the research insights that you need, right? If you can move on to the next slide, please. So then, okay, great. So semi-structured data can be handled in a form of SQL. So how do you handle unstructured textual information that usually gets captured in the form of medical transcripts, clinical notes. So here is an example of where you can actually throw medical transcripts. It can be in the form of PDF. It can be in the form of a blurb of information captured in a EHR workflow. You have ability to throw them into either a Snowflake stage or a Snowflake table, chunk them, parse them into smaller, chunks of information, and truly use the concept of vector embeddings to create the embeddings of, of those unstructured content. And then use a generative AI / large language model capability to ask a natural language question, right? For example, in this case, we have 5,000 medical transcripts loaded into Snowflake that were essentially coming in the form of a PDF files. Now all the data is stored within Snowflake, and we are also able to vectorize it. And we are asking a natural language question through this LLM. Hey, for example, can you get me the patient who has chronic glossitis as a condition? And the chatbot essentially prunes through and understands, okay, out of 5,000 medical transcripts, there are 2 medical transcripts that has this particular chronic condition mentioned or specified, right? Then you can ask LLM, okay, can you then summarize the treatment plan given to that particular patient, right? Then LLMs does a pretty good job of summarizing, hey, based on this particular search criteria, which is the search for chronic glossitis as a condition, here is the summary of treatment plan given to that specific patient where there was this condition, right? That's the type of the capability that these new technologies are unlocking that can truly help researchers get to the information that they need faster to conduct their research, right? And on similar lines, we also have built a similar chatbot interface to really query the information sitting out of PubMed data. So PubMed has a huge, information on all the research, that happens in the hospital and the clinical research space. Having this type of capability to ask a natural language question and retrieve the relevant and the meaningful information from the PubMed articles is a huge game changer and a productivity driver for researchers to conduct their research fast, right? And that's why we call this accelerating medical research, right? And this is technology that really helps to accelerate and cut down and be the researchers, be more productive, right? Now, you can go to the next slide, please. Okay, then great. We talked about semi-structured, we talked about unstructured. How about genomic data, right? It's one format, right? We talk about BAM files, we talk about variant call format. What you can do with the genomic data is you can take the variant call format data, and ingest them, parse them within Snowflake, and load them into a Snowflake table. And again, you use the data type of variant. And in this case, what we did was we took the 1,000 genomes data set, ingested and loaded them into Snowflake. But here is another interesting thing we did. We also taken the ClinVar database. ClinVar database is essentially a public archive of all the known associations that are published are found with the evidence of a genomic variant to a disease significance, for example, or essentially in any or a response to a given drug, right? And what we did with this is essentially took the variants and able to look up against the ClinVar database and say, okay, given that this specific patient's genomic sequence has a particular variant, and that particular variant has a known association to a particular disease, we are essentially able to publish the significance of a disease with respect to a particular human's genomic variants, right? Extremely powerful capability from a context of research to truly understand, what variants can truly cause certain type of, reactions from a particular patient's health, and truly use it from a research context, right? Again, wanted to give you a teaser in terms of, our capability to handle multimodal data. So then, great, right? Snowflake as a platform is highly scalable, performant, and has ability to handle multimodal data. But oftentimes, if you take a look at research, the research is actually conducted on a secure environment. right? What we call it as a trusted research environment. If you can go to the next slide, please. So in order to stand up a trusted research environment, there are certain key things, right? Obviously, when a research need to be conducted, the key things around, we have to preserve the patient privacy, right? What data is being used for that research study. And is the environment secure? Is the environment governed in terms of access controls and right levels? And oftentimes when a research is conducted, there are multiple parties who come together to do the research, which essentially leads up to collaborating from a context of research. And obviously, when a research is conducted, there has to be ability to handle multimodal health data, which is what the underlying research data is all about. Now, with Snowflake as a platform, you have ability to carve out, right? And I talked about how scalable or performant, how you can throw independent computing resources, for certain type of workloads and processing. Applying the same concept here, you can actually carve out a computing infrastructure that doesn't compete with others, right? This is not a shared computing model. This is not high performance computing clusters where you really need to take a ticket, get a ticket to get into a queue to even use that power. This is basically the power of the cloud, right? Where you have infinite scalability when it comes to the underlying infrastructure, and with that you have ability to spin up computing environments in the platform that has capability for multimodal health data, that comes with the bells and whistles when it comes to security, governance, access control, and so on and so forth. And more importantly, with the kind of computing environment that you are standing up, you can now attribute the cost associated with it. Because you are paying for what you are using, you now have ability to say, okay, I have stood up a trusted research environment that I am going to associate to a particular research study, which is again tied to a particular IRB approval and a grant. You now have ability to attribute the underlying computing resources and say, hey, okay, for this trusted research environment, here is the cost associated, because you are tying an independent computing resources in the cloud on Snowflake platform with which provides ability to attribute that cost. Again, extremely great way to manage and scale hundreds and perhaps thousands of research studies in parallel, yet have control over how you are using the underlying compute on cloud, right? Extremely powerful capability. And if you can move to the next slide, please. What we did is, Joe talked about our SI partners. We worked with one of our SI partners named Hakoda. What they helped us build is essentially a very small Streamlit-based application that helps researchers perhaps to spin up environments, right? So think of, this is a configuration tool where you go define, what type of environment that you want, and say, okay, I want this environment to be deployed. Boom, you have a database, a schema, some set of computing resources all stood up, but it doesn't stop there, right? Oftentimes, when a research environment is carved out, there is this base patient data that needs to be delivered to that, right? So there is a way to deliver the data needed for research through Cohort Explorer, and that's what this application is all about. It kind of tries to templatize the process and helps deploy a scalable environment to manage the trusted research environments. You can go to the next slide, please. You can go to the next slide one, please. Now, one of our customers, Francis Crick Institute, they were facing the same problem, right? So they conduct research. They're based out of Europe. They conduct large-scale research, and obviously they were, struggling with a shared environment, right? And if you can go to the next slide, please. What they are able to do with Snowflake is exactly leverage that independent compute and the platform capabilities, and able to spin up trusted research environments at scale with complete control of who's using what from a trusted research environment. And there are some published stats where they are able to significantly cut down the environment provisioning time from days to hours, right? And that's the type of impact that we are looking at by adopting such a platform and embracing the power of trusted research environment on cloud, right? With that being said, I will turn it over to Joe to talk about additional sessions and topics.
Perfect. Thank you, Murali. So this is going to build upon a lot of things. And just one additional note on the Francis Crick. They had told us that this original one where they're carving this out, and maybe your institution does this today, is to like literally send a hard drive to the researchers of the other institute of this, because it's too much data. We need it to be secure. They can destroy it after. It was taking them often months and sometimes upwards of $1 million to create a single TRE for another large scale institute. When they came to Snowflake, they were able to cut that down to less than 20 minutes. And really, because we're not copying the data, we're bringing people to the data. They're able to do it at a far, far less cost than millions of dollars. And so this allowed them to scale up and actually hit more institutions. This is, again, that ability to use this to accelerate your research, get more people in safely using your data, and win additional grants faster. One other thing, they built all these things. We'll make it available, so you can go out to the GitHub and actually download some of their approaches to this. But we'll provide those tools and links at the end as well. So on the second side, a little bit of an interactive things. I'm curious, when we say common data model in healthcare, I think you all have been in this space for a long time. There's nothing common about healthcare data. But there are a couple predominant healthcare models, and which ones do institutions pick? Which ones are predominantly used? Kind of curious, and if you're in the chat in Teams, can you let us know if you use OMOP, I2B2, or PCORNet, or a combination? Maybe just type O for OMOP, I for I2B2, and P. And I'm kind of curious if we'll see from folks in the audience, if you use any of these models, which ones are really common. And I'll throw mine just so you know where the chat is. O, I, or P. I think everybody can chat, right, Chris and Steve? Or do they have to use the Q&A panel?
No, they can use either one if I'm not mistaken.
Okay. And that's fine. Folks might be shy. We'll go through, and I'm just curious, and we can follow up later. If you're using any of these are the ones we commonly see. And often there's a combination of things. I think this is what we would argue is there's organizations that might have familiarity in I2B2, but then the study that they get into requires the PCORNet common data model. There's mappings that institutions and these actual consortiums are bringing together. And the tools that come along with those, with OMOP Odyssey, we'll talk through with Atlas or I2B2's Cohort Explorer, you may want to use something else. So we want to allow researchers and institutions to use any combination of these common data models, because it will open you up to collaborations with more organizations and allow them to bring the tools. I see a couple, I put a couple along the bottom that we predominantly see. Researchers want to be able to build things in Python. They want to use RStudio because that's what they learned in university. So POSIT is there. They're using SAS, which is really common across life sciences and pharma, or some AutoML tools like Dataiku. You can use all of these with these data models and in Snowflake because we allow you to just kind of bring your own BI tool, bring your own data science tools to the mix. And this, again, is going to allow your research to happen without somebody having to go learn a new tool or a data model. So on those fronts, I just want to quickly run through a couple of the common data models, what we're doing with the Odyssey organization. Odysseus Data Services, the kind of the group behind it. They worked with us and IQVIA to basically move the entire data model and set of tools to fully support the Snowflake Data Cloud. And with that comes along, of course, OMOP, the common data model, but also the Cohort Explorer, data classification, the federation side of doing federated analytics, and more. And all of these tools are freely available, open source. They're well supported, and maybe some of you are on some of the bi-weekly or weekly meetings where the Odyssey group gets together and talks through these different tools. So you can join and help influence the support and the build out of these features. So we see OMOP and Odyssey quite a bit. And there's some additional tools here that I want to note. And why we think it's really popular is that when institutions are working with life science companies, like an IQVIA, like the pharma companies, they often gravitate to the OMOP common data model. So if you don't have that, we want to give you a way to interoperate with that data model. And Snowflake is this huge network of over 1,000 healthcare and life science organizations. And we're finding they're gravitating towards OMOP in a lot of ways. So we wanted to fully support it and allow you to do this secure data sharing at scale. If you need help with this, we have teams, and our professional services team is very familiar with it. And many of our consultant partners are also happy to help you move from Epic to the OMOP data model, from Cerner to the OMOP data model. And one institution that's done that and has been really gracious in sharing that is up out of Michigan, and that's Corewell Health, formerly Spectrum, Priority, and now Beaumont. They've had Epic for a long time. They published this poster. They were part of the All of Us research program from NIH, which had a big component of OMOP in it. And so you can actually go out to the Epic user web if you have Epic, and they'll give you the code to help map between Epic Clarity or Epic Caboodle out to OMOP, all on Snowflake. And so we find we're often matchmaking folks and getting you there. If you don't happen to have Epic, that's fine. A lot of these components are very similar, and you can take their approach. They're more than happy to share the code that they build. That second category that we often see, and thank you for typing in. I see colleagues use OMOP. I'll keep watching the chat there. Feel free to add in. I2B2 is another predominant common data model and set of tools. You see some of these called out here. Mizzou is a group that really came out, I think, with a small grant, figured out how to bring that entire platform into Snowflake. And the reason they did it is because they're part of a large clinical research network called Greater Plains Collaborative. We'll talk a little bit about that here soon. And they had a lot of data. They were grappling with their on-premise solution, and I2B2 just was not cutting it. It was taking hours upon hours to work with this information and really hampering the amount of research that they could do. So they actually ported it all over. They have a lot of data, as you see along the bottom. They share the code out on GitHub so folks can download it, and it's being incorporated into I2B2 source code fully with folks up in Boston. I like to note too that this is a connection. There is a work group that's on the I2B2 side that works with OMOP. So these mapping tables allow you to expand into these other areas and support multiple data models. And as we said, we think that's really important. They also presented their work in a number of public forums in Boston last year and this year. And those recordings are out there. So we have a little link. If you're using I2B2, definitely encourage you to check out what Mizzou has done. They're, again, more than happy to share the code and what they've done to do that. Building on that, this is one of those videos that we wanted to call out. They realized with all of the different members of this Greater Plains Collaborative that they had to support multiple data models. So as part of a PCORNet CRN, they had to also support that data model. So they built the mapping between PCORNet and I2B2. And again, they're happy to share this, and they kind of show the breakdown. And there are gaps in these data models. Some are better for oncology than the other. So it's important to consider maybe multiple common data models, and Snowflake can help you stitch these things together and really give people the most appropriate window into the data to accelerate their research. And they call out in particular why this harmonization is very powerful, because it fills in the gaps that these common data models often have independently and allow the researchers to get at data in different ways. So something definitely to take a look into if this is in your space. Again, we'll share these links and videos at the end. On the next side is, a really important part of this collaboration that you have with other institutions is being able to safely and securely share it at scale. And so we want to talk about where this fits in with not sharing just the data alone, but also the algorithms, the code, the actual applications. And this is a component we often see as an accelerating research. And with this, Murali, feel free to jump in at any point too. I'll give my little bit of a history here. This is a project a couple years ago, and maybe people don't like to talk about it anymore. It's worn everybody out. But COVID was a huge thing. There's lots of data, and people needed to move fast. This COVID research database, COVID-19 research database, came together with a couple different institutions and groups needed to commingle this data and get results out quickly. Everybody was asking for it at the local, state, federal level, globally, and this research database brought together 85 billion records, was updated constantly by many institutions feeding in their data. It enriched it and allowed organizations to use their BI tool of choice. Tokenizing the data is really important across this entire thing. So you see Datavant and Mirador and SciOx often were involved in this. And this kind of concept really led to what we're seeing a lot more of, and that is this hub and spoke model. We'll also talk about spoke to spoke sharing. And this is where, very similar concept here. Academic medical centers can come together, share their data securely without copying it, bring together additional resources to enrich that data, kind of the marketplace resource side. And we want to be able to preserve the privacy, de-identify, tokenize. Our groups like Datavant and Samuha, which is a data clean room, allow those groups to safely commingle all that data together, built on the data models of Odyssey, OMOP, I2B2, and PCORNet, and then allow the researchers to use the tools of choice so that they can more quickly get to the insights, deepen their knowledge of the diseases that they're studying, get to predictive outcomes faster than they've been able to do because they have this at scale. And this is really a concept that we help organizations build out with that. And one is the Greater Plains Collaborative. And so on here is, fully published studies. You can go out to gpcnetwork.org. You'll see it's one of the large CRNs on PCORNet. And these 12 institutions, including some folks in your region, are using the Greater Plains Collaborative to do this work, to generate studies. And the grants, I think, will continue to get funded into the future to allow more organizations to join, more researchers to bring their work to this collaborative. And you'll see just along the bottom, we were at, it covers 230 hospitals across the nation, 34 million patients, 10 children's hospitals. There's a lot of data in here and a lot of studies and research that can be generated off of commingling this data across multiple states. And, keep an eye on the time. Please get your questions ready. We'll have some time at the end too. But of course, everything here is really predicated on the security and safety of that data. So Murali is going to take us through what we're seeing across organizations in this space.
Thank you, Joe. And if you take a look at preserving data privacy, from a context of research, ultimately it boils down to who can look at what, right? I mean, is the data approved for use? Is the data, are the data use agreements in place? Did this go through IRB approval process, right? So all of those bells and whistles are essentially super critical. And if you want to double click on, okay, great, right? Yes, there are process aspects of that in place, right? Which essentially is the data use agreements, the IRB. So, the way I always talk about this is it's a people process technology thing, right? At the end of the day, who's authorized to do what? That's a people aspect, right? The process aspect is, the data use agreements, the IRB approval process, what process is dictating, who gets access to what, and is the data right, from a usage perspective. And then there is technology aspects, right? And when it comes to technology, there are a lot of techniques that are available to ensure patient privacy, right? And, starting off with the basics in terms of when the patient data is handled, we want to make sure that the data is encrypted, the data, in motion, data at rest, when it comes to secure data storage, all of that is in place, right? Then we want to make sure that when the data is stored in a secure way, when the data is exposed for research purposes, right? How are we really enabling access control, right? How do we tie a particular user to an access, right? For example, role-based access control mechanisms, right? And so that access control is super critical. And then how do we make sure that we are understanding the type of data we deal with, meaning there is a PHI data, there is PII data, there is financial, sensitive data. How do we understand those sensitive data attributes and then apply different techniques based on what can be exposed versus what cannot be exposed to whom, right? Data masking is one such capability that enables you to mask the data when a person who doesn't have authority to view that data is trying to look at it, right? So data masking is a technique. Differential privacy is a very interesting capability that is coming up, where you try to create a policy that that sits between the data and the end user access, and make sure that the end user can only query aggregate information out of the data without exposing the patient level, record level information. And that is a classic use case when it comes to research, right? The first step in doing a research is shopping around for data, right? Okay, I want to go shop around for patient data. And in order to do that, you really need to understand, if you get a handle on, here is a population, patient population, right? You first need to understand, is this, do I have enough patient representation to the profile, that I'm looking for a particular research study? And that means you have to understand the demographics, the aggregate information of the patients to make sure that, yes, there is enough population, the cohort of patients that are of interest to me in that patient population. And having such a ability without exposing that, the detailed patient level data, having ability to understand the means, the averages, and so on and so forth is a super critical capability. And I'll cover a little more of that, later. Data minimization and other techniques are also, prevalent in the industry, right? Now, from a Snowflake perspective, we address this in a three-pronged approach, right? One is, if you truly want to protect the data, you need to know what data you are dealing with, right? So, capabilities like classification and tagging, right? Classification means, understanding, going through the data and understanding, oh, this looks like an SSN, this looks like a patient first name, this looks like a patient date of birth, and then tagging them as a PHI sensitive attribute, right? Or an attribute of interest from a patient privacy preservation standpoint is step number one. Step number two is, okay, now that you know the attributes, the sensitive attributes, and the patient cohort, how do you apply the protection policies, right? Which are the techniques of either tokenizing or data masking or row level access policies, restricting particular researchers to only the demographics of the patients that are of interest for that research, for example, right? And then the capabilities like the aggregation policies and the privacy policies, right? There are various techniques that are built within the platform that you can apply. And when you talk about research collaboration, enabling a secure collaboration is super critical, right? So how do you package some of these access controls along with when you try to collaborate using data collaboration techniques is step number three, right? Now, with that being said, if you can go to next slide. As I said, different privacy allows an analyst to to look at aggregate and statistics from the patient data, but it doesn't allow the patient level information or sensitive informations, right? So that you can never understand, identify a patient, but you can identify the representation of a patient population, right? Using this, and that's what that policy is. And if you can go to next slide, please. So how does this differ, right? So those SQL enthusiasts, in the room, these are three different queries, all trying to query data from patient table. One trying to directly query the patient level information versus certain filters versus an aggregate or a statistical information extraction from that patient population. As you can see, if you apply row level access policies, if you restrict somebody from a region perspective that, I don't have access to, patients from Canada, I only have access to patients from US because I'm a US resident. That kind of restricts that query number 2. And aggregation policy is essentially, if you take a close look at 3 and 5, if you try to get to a patient level information, the aggregation policy kicks in and blocks you from getting the relevant answer, right? But if you are really trying to apply a statistical, average or a mean to the patient data of patient's age, yes, the query will allow you and it will return the results. So right? If you are really conducting a study or a disease that's prevalent, in 50 plus population, right? For example, colorectal cancer, for example, right? It's prevalent in the aged population, and when the mean age is 43, you may immediately decide, okay, that patient data is probably not a best fit for me for that research study, right? But the difference between an aggregate policy and a differential policy is that the differential privacy introduces noise. So, right, so if you take a look at 8, it introduces and it returns a result, but introduces, hey, there is a plus or minus 90% variance, right? And what that means is, you cannot take a conclusion or you cannot get to the patients with this information because it introduces noise, right? Extremely powerful capability. We are super excited. This differential privacy is something is still in preview from Snowflake perspective, but we are super excited to have this, transform how research is conducted and using this. With that, if you can go to next slide, please. So there is, also a secure way to, collaborate with different parties when it comes to research using data clean rooms. The concept is that you don't expose your sensitive data, but you can do an overlapping analysis because the technology restricts you from accessing the data, but you can combine and get an aggregate view of information. Again, something similar along the lines of what we spoke. And if you can go to next slide, please. So we do have a spectrum, and if you can build the slide out, Joe, please. We have a spectrum of capabilities, right? All the way from secure sharing to row access policies to policy constrained access to a templated data clean room. And if you kind of compare this to the research needs, research uses pretty much all of this because the need from a privacy preservation standpoint, the answer usually is it depends, right? So here is different capabilities to address the different situations or scenarios that we face from a research standpoint, right? That's how suited we are from Snowflake standpoint to support research in a privacy preserving way, right? I know we are coming up on time. With that, I think Joe, maybe we kind of pause and stop. A few more slides we can cover, but at the end of the day, it's about de-identifying the structured and unstructured data, which is one of the techniques. And we can maybe pause for questions.
Perfect. I'll leave this one up here, and then we have a couple of resources. Again, thank you so much, Murali, for covering this. We covered 4 key areas here. Want to let folks know too, we'll be in your neck of the woods October 1st. We have what's called the Snowflake World Tour. There's a QR code. We'll get the link to everybody too. You're welcome to join us there. It's an enablement event. You'll hear from other customers, how they're using the technology. There's quite a few healthcare and payer folks that are interested in this. It's October the 1st. If you want to come have dinner with us too, we're running an event the evening just before. So wanted to throw that out there for folks in the area. Come join us. Hope the weather's really good. I'll be down there for that, and a few of my colleagues from the healthcare team as well. And then, let's connect. Here's our LinkedIn. We'll get that out to everybody. But thank you so much. We got a few minutes for questions, right, Steve?
Yeah, we've got one question. It's in the Q&A. It's a general question that says, related to patient data privacy. TREs typically have processes in place for data anonymization. Describe these processes other than blocking. Does Snowflake handle data anonymization, or do the individual institutions have to remove the PHI from films, notes, lab reports, blur faces related to photos and videos prior to sharing data? And who uses the data clean rooms? So that's a pretty long question, but it's in the Q&A if you want to read it.
Perfect.
Quickly, a couple of points around that. Snowflake supports data de-identification through our partner technologies. Those were the last two slides that I couldn't get to. Again, slightly synonymous to the anonymization as a technique, but if you have unstructured medical images or the unstructured clinical notes, John Snow Labs visual NLP model running on Snowflake is something that is predominantly used to kind of de-identify the necessary information. And then the other famous technique that's used is tokenization of data using data WANT, and then you de-tokenize when you are really applying the data for analytical or inference purposes, right? Those are a couple of techniques used from structured, unstructured, from a de-identification perspective. And then data clean rooms, it's essentially two different parties, right? So one of the classic examples is, for example, if you are in healthcare and you want to get into a value-based care contract, with a, if you're a provider and you want to get into a value-based care contract with a payer, and if you really want to understand the patient population or a member population that you are looking at, want to understand the health risk before you even design the value-based care contracts, payer and a provider can come together, exchange information without having to truly share the underlying data, right? They can just query each other's data, figure out, okay, I understand there are 100 patients who has this type of critical illness and so on and so forth, and use that as a means to kind of understand the risk and design the value-based care contracts accordingly. The other famous use case is marketing, from an outreach perspective, right? If there is a marketing firm that you are trying to use to outreach patients, from a context of what's the best channel of engagement and so on and so forth, this data clean rooms are used for.
The other one that we're seeing more and people are starting to evaluate is the health system and the pharma company. We have a new GLP-1 inhibitor. We want to see if there's patients that might be in your population that we could enroll in a clinical trial. Well, you don't want to send that to every pharma company under the sun. You're not selling your data, but you can enter into these contracts and arrangements. See, the overlap is enough that pharma company says, I want to enter into this. Health system says, that sounds good. You've done that overlap analysis earlier in that process, and then you win that particular study. So we see that being a quick way to accelerate those things too.
We have another comment and question. It says, this has been an amazing explanation of how data can be shared among researchers. As a clinical researcher at a university, I wonder how many universities have Snowflake as their platform. Do you know the answer to that?
As a one, I don't know the answer, and as a public company, I'm not sure we disclose the exact number of certain types of customers, but I can say we have 1,000+ healthcare life science, and in there we cover providers, health systems, payers, and also life science, pharma, medical device companies. It's about a third, pretty healthy. So about 300+ health systems, and in those, academic medical centers make up a decent chunk. So I think if you ask around, you'll probably hear this. That slide with the Greater Plains Collaborative is a good hint on some of the other medical centers that are using that. And so that stuff we're seeing kind of bubble up into research that gets published, and they will note we use Snowflake to process, share our data. But if you have particular questions, yeah, happy to connect and dive into that as well.
Okay, we don't have any pending questions, but prior to your presentation, a couple of questions were sent to me that people couldn't get on today. What is the scalability of Snowflake in handling large volumes of research data?
You want to take that, Murali?
Yeah, sure. So you get near infinite scalability because you can our query engine and our processing engines are extremely performant, and we are constantly making improvements to the performance of those engines And thereby, queries that used to take, 5 minutes to run, with those performance increase, it probably takes 3 minutes or 2 minutes. That means you can do more with less from a computing resources standpoint. And then we have a computing infrastructure in the form of t-shirt size, right? So we have small, medium, large, all the way to 6 XL, when it comes to the computing infrastructure. So if you are really looking at, for example, genomic data, 1,000 genome data set, we are really looking at billions of records or petabytes of data. You can tap into a higher computing infrastructure and use that as a means to process. And once you are done with that high capacity workloads, you can just drop off the computing infrastructures, and you only pay for what you use.
And it's to put some numbers that we're aware of. Mentioned University of Missouri a couple of times, so they have shared this on YouTube in their presentations at HIMSS as well. And there were processes that were taking 12 to 20 hours to run with SAS, and they moved it to Snowflake, and they get it in a couple of minutes, sub 10 minutes. So that type of scale allows them to do their research faster. Now, there's some things where that's fine that they want to run it for hours overnight and get it the next day, but there were a lot of instances where they needed that to be in the minutes and seconds range and not days and hours.
Right. By the way, as y'all was speaking, one more question came in, and this dovetails nicely with our time limit. I think it's our last question, but it's an excellent question. Number one, they said a great presentation, but have the academic medical centers been able to collaborate and share data housed in Snowflake? What sort of permissions have been used, and what challenges are faced?
Perfect. I'll start a little bit on that, and Murali, feel free to add that GPC that I showed with the institutions, that was part of that. How are we going to get 12 unique institutions with various implementations of different EHRs, lots of data, to securely house and commingle their data together? Those role-based access controls were part of it. They also de-identified information as it was landing into the environment for everybody to use. So with a combination of the tokenization, data masking, and policies, they now were able to quickly unleash researchers and know exactly what they should be able to see and not see, and to what extent. When an IRB was approved, now we can re-identify some of this information. But if not, they're out shopping, like Murali was saying, making sure that their hypothesis had enough data behind it. And that was all part of the permissions and security. So challenges they faced there, I think that was maybe learning new technology, a different approach here. But that was something that they worked with our organization to better understand how we can help secure that data with them.
Yeah. And another topic I would add on to that is essentially, all sorts of these data sharing from a collaboration perspective eventually goes through data use agreements, the privacy preservation techniques that we spoke about. What is the level of privacy preservation? Was consent involved, right? So all of the process aspects that typically happens from a research workflow standpoint doesn't go away, right? At the end of the day, so we usually joke about this, right? The technology is there, right? The process needed to now catch up to leverage these technologies and kind of truly drive accelerated value in research. And oftentimes process is the bottleneck, not necessarily technology.
Well, I want to thank you, Murali, and thank you, Joe. This has been a great webinar. Lots of good questions that came in. Chris Wilson, as you know, will record this, and he will get this out to all the people, that have registered for this. Even if they weren't on, they'll be able to get a recording of this. But we can't thank you enough. We appreciate your support of the Dallas-Fort Worth Hospital Council, and we will now end this webinar, but thanks so much for a great presentation.
Thank you very much. Thanks
Thank you.
all. Take care.
Bye-bye.